Hi, everyone, and welcome to the Muslim Sex Podcast. I have some exciting news. I want to let all of you know that I am opening up my office, my private office, where I can see you here in New York, and it will be opening at the end of this month. So this month is now June. So at the end of this month, my office will be up and running, and I would love for you to come in and see me as a patient. So go to V Health, so that is FEMMEVIEHEALTH.com, and sign up to be a member of my concierge gynecology practice. And you can also come to, or if you have a problem visit, come and see me. I, of course, focus on menopause and sexual health. So if you're having any of those issues, I'd love to see you. And make sure you come in and say hi. I'd love to meet you in person. So also, the retreat is still going on. It'll be happening September 16th through the 23rd, and we only have a few spots left. So if you were thinking about coming to the retreat where we focus on nutrition and sexual health and menopausal health, you need to register today because spots are filling up. And once it's sold out, it will be sold out and we will not be taking any more participants. So make sure you go and register for that as well. Also, as always, please remember to like and share this podcast. Leave me a 5-star review so that it shows up and so that we can get the word out about menopausal and sexual health, as well as intimacy and intimacy coaching. So if you love this podcast, please make sure to leave me a 5-star review. And now on to the episode. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about vulvodynia and other vulvar conditions. Before we get into it, a few things I want to make clear. I am definitely not giving any type of medical advice. If you have any questions about your health, please speak with your friendly healthcare provider. And if you have any questions about your religion, please speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I am super excited to have on with me the great Dr. Jill Krapf. Dr. Krapf is joining us from Florida. So Dr. Krapf, please introduce yourself to the listeners and the viewers that may not know who you are.
Yes, hello. I'm so happy to be on with you. So my name is Dr. Jill Krapf, and I am a board certified OBGYN who specializes in vulvar pain conditions, as well as skin conditions and chronic vaginitis, pretty much anything that has to do with the vulva or vagina that causes discomfort or causes sexual dysfunction. And my practice is based in Tampa, Florida. I'm also a researcher, and my research interests include lichen sclerosis and vulvodynia. And I am a co-author of the book When Sex Hurts, second edition, which has been out for over a year now. And so it talks about the different types of chronic vulvar pain, which I think is what we're going to be getting into today.
Yep, absolutely. So that is amazing. And I have that book. Actually, Dr. Goldstein signed it. So next time I see you, I'm going to have to bring that book so you can sign it as well. Dr. Andrew Goldstein signed it. So I would just love to just get into the episode. So I know you talk about chronic vulvar conditions. And just for those people that may not know, of course, we're talking about the vulva, which is the external female genitalia. And so what are some of the most common conditions that people tend to come to you for? I assume they're having pain for a long time when they see you.
This is true. So I see pain conditions of the vulva. Some people describe it as the vagina, but almost always the condition involves the opening of the vagina called the vestibule, which is a part of the vulva, or the external vulva. So most people, when they come to see me, they will describe a burning sensation or a discomfort or pain sensation when things rub against the area or touch the area. Sometimes that involves intercourse, penis in vagina intercourse, and sometimes it doesn't. Sometimes it's day-to-day living what they're doing every day. And so a lot of that often gets lumped into this term called vulvodynia, which essentially means chronic pain of the vulva that has no identifiable cause. Unfortunately, we do need to term these things for research purposes or guideline purposes or to group them in certain ways. But when we give a patient a diagnosis that has no identifiable cause, it's really, really difficult to treat that condition. Now, we know that everything has cause, right? Everything has cause based on how the body works. And so, what I try to do in my practice is to figure out the cause, more likely the causes of the pain that's contributing to the symptoms that someone's feeling. And then once we figure out what the causes are, then we can develop a focused treatment plan with those causes in mind. And that's how a lot of us experts that have been doing this for a while and have been seeing patients clinically and doing research in this realm, that's how we treat patients, and we have good results with treating people with chronic vulvar pain conditions.
That sounds amazing. So, I know that definitely, the most common thing that people come in for, a lot of times when you talk about vulvodynia, I know a lot of times that can be like yeast and things like that. And you're so right. And most obstetrician gynecologists, right, you and I are both OBGYNs, and we don't really get very much focused education on the vulva. We have to learn about so many things. We learn about obstetrics, we learn about pathology, we learn about cancer, we learn about all this stuff, but we definitely don't, at least I didn't in my training. And that was in the early 2000s, that I didn't get really any, focused treatment, or not even treatment, but education on the vulva and different vulvar conditions, lichen sclerosis, lichen planus, all of those things. We just didn't get any education on. So I'm curious. So I know that you focus on these conditions. Now, did you do extra training I know you trained a little bit, you trained with Dr. Goldstein. Is that correct? Andrew Goldstein?
Yes, this is correct. So things were not that much different when I did my training, which was in the mid to late 2000s. And I was very fortunate in my career that I happened to attend a residency program that was across the street from one of the world's experts in all of this. And then we had a chance meeting in the operating room when I was a chief resident. And I was able to attend a vulvar vestibulectomy with Dr. Andrew Goldstein. And basically, that is a very specialized surgery where we remove the actual opening, the vaginal opening, in the case that someone is born with too many nerve endings at the opening of the vagina. And so I attended this surgery with him, and I was about to graduate residency in OBGYN. I was a full-fledged MD about to graduate to become a OBGYN, and I really did not have a lot of experience in pain conditions, at least not the ones that he was treating. And I was very interested in learning more about it after I spoke with him during the surgery and I did the surgery with him. So the following year, I was planning on doing a fellowship in medical education. I thought that at the time, I thought that I wanted to be a dean of a medical school. I was very interested in education. And so I did a non-accredited fellowship in medical education where I was working part-time to pay my way and earning a master's in medical education, along with a cohort of a lot more experienced people within the university, which was a great opportunity. But that gave me some time for research, and I was the first fellow to go through that program. So I essentially was able to develop my curriculum. And so I decided that I wanted to clinically spend as much time as possible with Dr. Goldstein to learn about what he did. And so essentially, I did 2 unaccredited fellowships in 1 year. And then following that, I joined faculty at the George Washington University full time, and I started the Center for Sexual Health at that time as a junior faculty member, which was a tall order.
Yeah.
But what was interesting is they had not had a center for sexual health since the 70s. And so I brought that back in 2012, and I was paired with a older gentleman who is a urologist who had been in private practice for 35 years. He tried to retire. His wife basically said, "You need to go back to work because we're going to kill each other." And so he had sold his practice, his private practice that he ran for so long. And so he came to GW to work part time just to get out of the house. And we were paired together because he was treating all the men with erectile dysfunction. And then what do you do with their partners who basically had to figure out how to have intercourse with the men that were being treated, but it hurt. And so
Right.
that's where I came in. And so I was really, it built up the practice very, very quickly. I trained 2 nurse practitioners because the volume was so great. And I did that for a number of years. Before, for family reasons, my husband is a pediatric surgeon, so we moved around quite a bit. And then he was also in the military. It was like a double whammy. So I was in Texas for a while at University of Texas San Antonio. I was doing the same thing there while practicing full breadth OBGYN and running clerkships at both institutions, one after the other. And then
Wow.
in 2019, Dr. Andrew Goldstein, my mentor originally, he said, "Hey, do you want to join me in this practice and eventually take over this practice?" And I said, "Yes, I'll be there." So the stars aligned with my military husband's career, and we were able to move back to DC. And so I ran the Center for Vulvovaginal Disorders in DC for a little over 4 years before I moved down to Tampa to start my own practice in Tampa doing exactly this. So
Wow.
it's been quite a journey, but that's been my education behind it. When I went through everything, there were no fellowships for OBGYNs in this subspecialty. There was a fellowship with Dr. Irwin Goldstein in San Diego for urologists. And a few of them went through, like Dr. Rachel Rubin, who's one of my good friends. And so there was that. And now there's actually 2 fellowships in sexual medicine, one at the George Washington University with Dr. Sarah Signa, and one in Cleveland with Dr. Rachel Pope. So 2 opportunities for OBGYNs to do fellowship in this area of practice.
It's amazing. I had no idea that there were actually two. I know the one with Sarah, but I didn't know the one with Dr. Pope. That's amazing. And that's so needed. As you know, there are definitely not enough sex med practitioners to help all the women out there suffering. And typically, I mean, I find that a lot of women suffer in silence, right? Because they just, one, there may be some shame or stigma associated with pain with intercourse or just sexual pain. And then secondly, you just don't have very many providers. You know, if they go to a general OBGYN that they're hoping may know what they have, that general OBGYN is not trained. And so they just don't know. I think that I didn't even hear about, the terms vulvodynia and vestibulodynia until, I took my course through the University of Michigan in Ann Arbor. They have that year-long sexual counseling and education course. So I did that course, and then I became an ISWISH fellow and took some courses with ISWISH. But I mean, really, you just don't, unless you go out and seek out information on sexual health, you just don't get it, unfortunately. So I'm so happy to hear that there are definitely fellowships.
Yes, you're right. I mean, in our training, OBGYNs are expected to take care of such a wide breadth of topics and patients, everything. It's basically all women. What other specialty treats an entire 50% of the population? And so it's really difficult because there's such differences with obstetrics care versus general GYN surgeries, right? And there's specialists. There's specialists for cancer, there's specialists for infertility and endocrinology, there's specialists for high risk pregnancy. And my hope is in the future that this will be a fellowship based subspecialty of OBGYN as well. And honestly, it should not just be OBGYN. I think it's multidisciplinary, and that's one of the strengths of sexual medicine. So my
Right.
hope is that urologists or primary care or anybody that's really interested in it could be able to do this. And so at ISWISH, we started a sexual pain course, genitopelvic pain course. And that was over 2 years ago. We ran the first one virtually, and it was a hybrid course. So half of it was virtual, and then there was a hands-on session at the meeting 2 years ago. We ran that, we're running that again. We're in the middle of it, the virtual portion. And then we have a hands-on session that we're currently planning for the spring, for the ISWISH annual meeting in the spring. So really, yes, it's something that if you want to know how to do this type of medicine, the sexual medicine and vulvar pain conditions, we really do need to seek that out, because we are not trained typically in residency or even afterwards. But there are opportunities available.
That's fantastic. That's so great to know about all the work that ISWISH is doing to, bring this to the forefront, but also to train people that may not be able to, for lots of reasons. And they may not be able to go through a whole fellowship or a year-long fellowship to be trained in all this, but still, have the desire to help women. And, there's so many vulvas outside in the world. There's lots of work for everyone. So I think that, it's great that there's no gatekeeping with this, and that, that they're, the people that know, that are trained, are willing to train others. I think that's fantastic. So I'd love to hear more about the type of patients that come to you and what type of conditions you commonly see in your practice.
Exactly. So everybody that comes in pretty much has the same, what we call chief complaint, which in medicine is what brings someone in the door, right? And it's generally burning down there. Burning, they usually say vaginal burning, but when you get to the heart of it, it's usually vulvar or vulvar vestibule, which is the part of the vulva. So that's what brings people to me. There's variants of that. Sometimes it's burning with intercourse. Sometimes it's burning when I sit. But it's generally this burning sensation. It feels like a yeast infection, but all the tests have been negative, or they've been treated up and down for every type of yeast or every type of vaginal infection, and nothing's helping, right? And so when somebody comes to me with those symptoms, I tell my patients there's 4 general buckets of cause that could be at play. And typically it's more than one, right? And then within those buckets, there's different diagnoses depending on their history and physical and what's going on under the surface. So starting with those 4 buckets, the first bucket is hormonal. So when we talk about hormonal and we talk about things like menopause, that's fairly well known now. We understand that in menopause, our ovaries are not ovulating, and the production of hormones like estrogen, testosterone, and progesterone all decrease. Testosterone is more of a gradual decrease, not a drop like it is with estrogen and progesterone. But we can see effects anywhere that there are hormone receptors. And there are hormone receptors in the genital area, and mainly at the vulvar vestibule, where there's glands that produce our natural lubrication and keep that opening area called the vestibule healthy. And I think what we're starting to see, what the research is showing, and what we've known clinically for quite some time, is that the receptors, the estrogen and testosterone receptors, are on a gradient. So the further we get into the vagina, there's more estrogen receptors. And then as we go down towards the opening, there's actually more testosterone receptors. And at the vestibule, it's very heavy in testosterone receptors because it's homologous, meaning it's similar to the male prostate. Just as we're forming men, that area encloses and becomes the prostate, and the ejaculate forms within it. Whereas with women, it stays open and it's more like a car wash, right? And so when we start thinking in this way, the urologists knew this for quite some time because they compared, males, females, penis, vagina, vulva, and then they're thinking of the urethra and the bladder as well. But us gynecologists, it takes a little bit of thinking to kind of open our minds to, oh yes, this makes sense. And the most recent research is staining for these receptors in the vestibule and showing that there are many androgen or testosterone receptors in this area. So it changes the way that we think about replacement or treatment as far as topicals. So that's one bucket of cause. Now, where it gets a little bit more tricky is, oh, yes, menopause. Everyone completely understands that. But there are times physiologically and non-physiologically in our lifespan that mimic the idea of menopause, right? So, for example, there's certain medications that decrease the amount of testosterone that works, right? So, spironolactone, which is an acne medication, certain types of birth control pills in certain people, right? And all of the effects of medications that decrease testosterone or increase sex hormone binding globulin that binds to testosterone, the effects of that are going to depend on our genetic makeup and how we respond to this medication, right? Then you think of it like a side effect. So we see that in younger people. We can also see a similar picture in perimenopause, right? It's the same thing going on. And then in postpartum and lactation, we can see a similar picture. And so that idea is something that I think we understand as sexual medicine providers, but it's starting to gain traction for gynecologists, urologists, and other medical practitioners. But that's a hormonal bucket. And then it's the figuring out what causes the issue. But on the exam, I can tell that immediately because the glands at the vestibule, at that vaginal opening, if there is a hormonal cause, are red, and you can touch a millimeter outside of them and there's no pain. And then you touch the gland itself with a wet Q-tip and there is pain. And so that is immediately something that we can tell. It's not something that a regular gynecologist or any other doctor has been trained to do traditionally, but we can train people to do it. And that's a part of my exam. So that's pretty straightforward to identify for me. So that's the first bucket of cause. The second bucket of cause is muscle related. And so we know that we have pelvic floor muscles that create a hammock at the bottom of our pelvis. And I think I want to expand this idea, right? Yes, pelvic floor muscles, most people can kind of wrap their heads around that. But we really want to expand this and think of the pelvic floor muscles like the bottom of a soda can or a pop can, depending regionally where you are. So the diaphragm is the top of that cylinder, of that can. Your abdominals are the front, and your paraspinous or your back muscles are the back. It's a full dynamic situation, right? And we also know that tight pelvic floor muscles are connected to jaw clenching as well. And so we're really looking whole body here. We're just not looking just at the vagina or the vestibule or the vulva. And so muscular causes are another bucket. And basically, this is when the muscles are hypertonic, which means tight. So tight pelvic floor muscles restrict blood flow, not only to and through the muscle, but to the overlying tissue. And depending on the muscles affected, this has effects on the tissue of the vestibule, the outside vulva, the rectum, the urethra, the bladder, the lower back, the sacrum, your tailbone, right? So it has effects on all of these structures because of not only the tightness, but the lack of blood flow, which is carrying oxygen, nutrients, and hormones to not only that muscle, but the overlying tissue. So often there's muscle issues at play. And if the muscles are tight, remember these muscles are wrapped with a saran wrap called fascia. And within that is sandwiched the nerve that runs through that area, as well as the artery and vein. And so that nerve that kind of runs under the pelvic floor muscles is called the pudendal nerve. You have one on the right, one on the left. And so when that gets functionally entrapped or squeezed based on the muscles being tight, then we start getting feeling symptoms on the vulva, such as, neuropathic itch or discomfort or pain with sitting or pain with wearing underwear. But it's usually a functional issue with the pelvic pelvic floor, although it can be higher up in the circuit. And then the third bucket of cause is going to be nerve related, which we already went over how the pudendal nerves are involved, but it can also be related to nerve issues higher up in the chain. For example, if someone has something pushing on their a disc impingement, right, or a lower back injury, a tailbone injury, all of these things can be connected. It's just the vulva is the end organ. It's like sciatica, right? If you said you had toe pain because you hurt your lower back, no one would think twice. They're like, oh yeah, sciatica runs down your leg, your toe hurts because you hurt your lower back. But if someone says, I have vulvar pain, or I have clitoral pain, or I have unwanted clitoral sensation, PGAD, persistent genital arousal disorder, and it's because of the nerves and it's coming from your lower back, this seems to be more sensational. But I believe in time, we're going to start understanding that this is just a way that somebody can have an injury, and this is how it manifests at the end organ. And then with nerve, the other type of nerve is we believe some people are born with or develop too many nerve endings in the vestibule, that opening area. And when we're talking about that, we're talking about nerve endings, not the big nerves that we were talking about before. So there's treatment options geared towards that. And then the last bucket of cause, so we talked about hormone, we talked about muscle, we talked about nerve. The last is inflammation. And I always put that last because it's usually the first thing that we as OBGYNs check for is infection, inflammation. So by the time somebody comes to me, they've generally been tested for every sexually transmitted infection that exists and every yeast infection that exists. But when we think about inflammation, we also have to think about autoimmune skin conditions, such as lichen sclerosis, lichen planus, lichen simplex chronicus, itch, scratch, itch cycles. And then we also have to realize that there can be constellations of conditions like connective tissue conditions that have a histamine reaction component. So that can kind of tie in as well. And then the other thing we have to realize is when there's a lack of hormone, a lack of blood flow, tight pelvic floor muscles, that also can create an element of inflammation within the tissue. And that's why these things tend to all present in the same way, even though they have a different constellation of cause.
That is amazing and so thorough. That
That's
was
the
fantastic.
5-minute overview.
That was fantastic. I think you broke it down so well. And, I mean, obviously I was following, but I think anyone that, is truly listening can follow exactly what you were saying and all the different causes and all the different buckets that you talk about. I love the analogy of the diaphragm and the pelvic floor muscles as a soda can. I never thought of that, right? With all of the rectus muscles in the front and the paraspinous muscles in the back, and how all of those are definitely connected. So if you're having some dysfunction in your pelvis, it may manifest in your back, right? Those people that have chronic pelvic pain probably also have chronic back pain and vice versa. So really interesting. And you hear about those pelvic pain docs always talk about not sitting for prolonged periods of time, right? Getting up and moving around and alternating between sitting and standing, because you don't want to make those pelvic floor muscles so tight. So I think that's really amazing how you broke that down. And it's so important because we definitely don't learn that. And it's so fantastic to have a practitioner on that does practice all of this and that can break it down. So in terms of, when you go and you examine a patient, of course, you're doing the Q-tip test, but, you're also checking for how tight those muscles are. I'm sure you're probably also checking for infections. But like you said, by the time that you see them, most patients have already been tested for everything and generally come out negative.
Exactly. So I don't do a lot of routine sexually transmitted infection testing because, you know, for my patients, they've seen an average of 7 doctors before they hit my doorstep. So I'm not going to repeat their gonorrhea and chlamydia testing when they're in stable relationships, and that's just not part of the equation. It's the inflammatory or infectious testing that I tend to do tends to be things that are not picked up by routine testing. For example, if someone has something called desquamative inflammatory vaginitis, or DIV, which is a yellow sticky discharge, There's three general causes of that, and one cause can be in bacterial or aerobic vaginitis. So sometimes the testing that I'll do is more broad spectrum. Like I'll do a PCR next gen sequencing of the vaginal microbiome, so I can interpret it and get kind of like a lay of the land. So I can put that in context clinically, and see, what may be causing their immediate symptoms. But I always tell patients, even if there is chronic yeast, even if this is a recurrent infection, the question is why. I like
Mm.
to think of infection as a symptom and not a diagnosis. So, why are you, as a 30-year-old, having recurrent yeast infections? Why is the vagina not being a self cleaning oven like we know that it should be? And so, usually, the answer lies in that it cannot clean itself, be a self-cleaning oven, because it doesn't have the building blocks to do so, whether that be hormonal, whether that be muscular. Perhaps there's not enough estrogen to support lactobacilli, which are the good bacteria in the vagina, like the guard cells that kind of keep everything under wraps and prevent overgrowth of bacteria. Perhaps it's related to that. So I really like to really look under the surface, and really think of infection as a symptom rather than let's just keep treating and treating and treating and treating.
Yeah. When you were talking about inflammation and, let's say, for example, recurrent yeast infections, I sometimes wonder if, underlying diabetes, right? Maybe a patient doesn't know that they are diabetic, or maybe their diet, maybe they're eating a lot of carbs. I always ask what type of foods they're having and what they're eating, and if they're using, some patients don't realize that they're not supposed to douche, things like that. I always ask. And I think you also on your Instagram have a little diagram. I love your little paintings, your drawings that you do,
Yes.
because I think it's very helpful. And I think it really helps to kind of break down what are the causes, what are the things that may be causing your inflammation in your vulva if you're having that. Outside of doing all those exams, then I assume, are you also referring them? I guess it depends on what the cause of the pain is. But are you also referring to like a pelvic floor therapist? And at what point do you also get a sex therapist?
Absolutely. So, sex med is a team sport. It's multidisciplinary, and so I kind of I had one patient who had overactive or hypertonic pelvic floor muscle dysfunction. She had a bit of nerve involvement, some hormonal component, but the biggest part for her was the tight pelvic floor, and so I readily refer to pelvic floor physiotherapists, occupational therapists, physical therapists, anybody that specializes in pelvic floor muscles and nerves, and connective tissue. They really do the whole thing. To really help, because we do need retraining of those muscles, and sliding and gliding of the nerves, and just a functional system, which is what physical therapy is about. It's about restoring function. But my patient, she lovingly referred to me as the captain of the ship and her physical therapist as the rear admiral. And if you've ever been to a physical therapist or dealt with these conditions, you know why. You know why. There can be some rectal work that is involved sometimes, depending on your symptoms. But I thought that was really interesting, because I do like to be the one that figures out what is going on and then determine what is needed as far as developing a comprehensive treatment plan. And so sometimes that treatment plan is all in-house for me, but sometimes that treatment plan involves pain management and rehabilitation doctors, PM&R, to do pudendal nerve blocks or ganglion impar blocks or epidural blocks, or perhaps there's a disc impingement and we need to get our friendly spinal surgeon involved, or perhaps there's a labral tear of the hip that's causing the tight pelvic floor and we need to get our hip surgeon involved. Sometimes obviously physical therapists, sex therapists are very helpful in this journey as well. Sometimes if there's an issue with the uterus or with pelvic organ prolapse. Then my friendly urogynecologist comes in, or a urologist if there's interstitial cystitis picture, recurrent UTIs. But it's really about figuring out what you have in front of you and what all the contributing factors are. Because until we determine that, it's really hard to develop a treatment plan. And treatment plans have to be done in a thoughtful order. So, for example, if I had somebody who had a hormonal component at the opening of the vagina, at the vestibule, and they have tight pelvic floor muscles, they have these two things, and I told them just to go to physical therapy without treating the hormonal component, it's going to be extraordinarily painful for them to do any internal work, whether that be myofascial release or whether that be dilator therapy or whatever it is. To get into those muscles, they still have this crazy pain generator at the opening of the vagina. They just can't get in. So it's really essential for me to identify that and to treat the tissue at the opening first to make it healthy and bulky and withstand anything, so they're able to get in and then release those pelvic floor muscles. So it's really about not only the diagnoses, but the order of things. And that's where the art of medicine comes in with this topic.
Yeah. It's really so good, and so many pearls in there that you're, talking about, and also letting individuals know that may be suffering, kind of what your thought process is in terms of, what you do first, then second, then third. I always, I see it as a triad, just as you do. There's a sex med doc, there's a pelvic floor therapist, and of course there's a cognitive portion of it, which I think is actually sometimes even more important, because somebody that's been suffering for so long is going to have that fear of pain. They're going to have that anxiety. They're going to worry about, whether or not, even after they've been treated for whatever it is that is causing their pain, is it going to come about again? And then I feel that, sometimes these individuals also develop secondary vaginismus, right? Because they're always worried about that pain. They're worried, is it going to hurt, and this and that. And so I think you also have to work through that component of it as well.
Yeah, I find I'm not a sex therapist. I'm a sexual medicine doctor, a gynecologist that specializes in this. But I do sprinkle in and incorporate elements of CBT and, just other psychological elements within my treatment plan, because it makes it more effective.
Yes.
So I'm a firm believer that if you know the why behind something, it's going to take some power back, because you know why you're doing the treatment plan that you're doing, and you're not so afraid of what's going on. And so if someone has this unknown burning and we label it as unidentified, and then we tell them to go to physical therapy, or we give them some cream and we don't explain what it's doing or why it's doing it, that treatment plan is going to fail. And it's not because of the patient. It's going to fail because there's no explanation or communication or why behind what you're doing. So why, as humans, would you stick with something that doesn't make sense to you, right? And so I really try to do that. I was an educator. I am an educator, but I was a formal medical school educator for almost a decade, teaching medical students how to be OBGYNs. And now I teach patients and other practitioners, but mainly patients, about their condition. And let me tell you, we went into a deep dive of pathophysiology of this condition earlier in this program. And I will tell you, I do that for my patients, depending on what their underlying cause is. They get it. Patients get it. It doesn't matter if someone's a hairstylist or they work a desk job or they're a realtor. It doesn't matter. They get it more so than many of the medical students, because they're adult learners, they're living it, and it makes sense in their body. And then it helps them develop a treatment plan that they have control over. And then once they get control back, they're able to see how they're getting better, and they're able to get better. So I'm restoring power through education, which is funny because it comes full circle with what I was trying to do initially as, a resident, just graduating residency and doing a medical education fellowship. Who knew?
Yeah, that's fantastic. No, you're absolutely right. When you inform patients, when you explain to them exactly what is going on, then it definitely gives back the power, right? I'm sure when they come to you, they feel hopeless, they feel helpless. And then when you start to educate them and they see the results of the treatment that they're getting, then that definitely gives them the power back and the agency over their own body and their sexuality, which is so important. And I think that empowering patients, the way that you do through education, I think is probably really what makes the difference, right? And also the time. I
Oh,
think that what people don't understand is that, when you've been suffering for so long with this condition of vulvodynia, you really need a practitioner that can take the time to focus on that, right? You need somebody that is not going to run out in 5 minutes because they have a baby coming or they have to go do emergency C-section or something like that. They need somebody that has the time to sit and explain what's going on. Otherwise, they can just go to their regular doctor and spend 15 minutes and then get dismissed for their pain, right? And just be treated for another yeast infection when that may not even be the cause. So it's really
these
having the time you have.
conditions these conditions are truly chronic pain conditions,
Yeah.
right? You
Yeah.
cannot treat chronic pain in 15 minutes. You just can't. And
Yeah.
the other thing that I do is I really find out patient goals from the get-go, because not everyone has the same goals, and it's not my position to push my goals on anybody else, right? I have patients that their goal is to have penetrative vaginal intercourse with their partner. But then I have patients that their goal is to wear underwear.
Yeah.
Like I there's so many, and the goalpost, the functional goalpost can change based on how someone's doing. So we always want to reevaluate that. But it's important from the get-go that we understand what somebody's goals are, and what they're trying to achieve, what they're trying to do. And you really can't do that in such a limited amount of time, unfortunately. So I think as OBGYNs, we're actually set up for failure in these situations with these patients. Unfortunately, it's not that people don't want to help. It's not that we don't, it's just that I think the average OBGYN, number one, wasn't trained. They want to help, they just don't know how. And then the resources are such that not only are they don't have resources, it's like anti resources, to really address these conditions. And so I think it's absolutely necessary that there are specialists out there that want to see these patients, that want to do this. Now, the downside of that is access, right? A lot of the specialists, in order to be able to accommodate a 120-minute, right, or 90-minute visit with somebody, and to get to the root of their problem and to give them the specialized care and to call them back with their results and to have that personalized care. Unfortunately, our current insurance model in the United States does not support that level of care, at least not in the outpatient setting, right?
Yeah.
And so that's the issue that we're coming up with now, is an issue of access, and resources, because the care is available, but we don't have a healthcare system that supports this type of care for patients.
Yeah, absolutely. You're so right. And, unfortunately, it can be a little bit expensive, but then you think about that, how long has this patient been suffering with this condition and how long, how much has that cost them, right? Going from doctor to doctor to doctor. And so when they finally find a doctor that understands, one that listens, right? Because a lot of times doctors don't have time to listen. So a doctor that's going to care and understand and listen and then treat you and then take the time, like you said, like 90 minutes, 120 minutes, it's going to cost a little bit of money because that doctor needs to spend so much time with you to really get to the root cause. And I think that, that money, that investment in yourself is so worth it, right? Because think about where you're going to go from here, right? You're only going to move forward. You're not going to regress. So I think that's fantastic that.
Absolutely. And I think a lot of patients do realize that. I do feel for both the patient and the practitioner, right? Because this is out of both of our hands. We're not making the rules for insurance. Our expertise and time and dedication has value, has a lot of value, right? And so I think that, obviously things have to change in that realm. But I agree with you. It sometimes is more effective to see a specialist, to get the answers, to get on a treatment plan, even if the upfront cost is higher. It actually may be a savings in time, energy, and even money. I've
And
had
mental
people,
health.
and
Yeah.
mental health, which is priceless,
Yeah.
which is priceless, absolutely, because there is such thing as medical trauma.
Yeah.
And when somebody goes from doctor to doctor and gets dismissed over and over and over about something that's truly happening in their body, whether that be neurologic, hormonal, muscular, that has a trauma to it, right? There's a mistrust, there's a defeatism, and that's honestly another barrier to getting well, right? Even if you find the right practitioner for you.
Yeah, absolutely, 100%. I mean, this conversation has been so amazing. I just love it. I had a practitioner actually call me the other day, and she's like, "Oh, can I ask you a question really quick? So in 5 seconds, can you tell me how I can treat decreased libido?" I was like, that is a very long conversation. I'm like, there's no, there are pills, but I said that you have to go through everything. There's so many things, biopsychosocial, blah, blah, and I said, there's no way I can have this conversation with you in 5 seconds. I said, why don't you come over and let's schedule a time to talk about this. I mean, there's no way, right? People want a quick fix. Even practitioners, they just want to know, like, how do I treat this really quickly so I can move on to the next patient, or treat this, treat that. And I said, it's
Yeah.
just
I tell my patients, if there was a magic pill for this, if there was a quick fix, you would have been treated 10 years ago.
yeah,
It's just, unfortunately, we're not there. And because it's there's many different inputs with these conditions, there's just not going to be one magic pill or magic topical that's going to cure everything. But it
yeah,
is interesting when you're not in it. We have to put ourselves in the heads of patients and practitioners that are not in it. There is this thought, oh, I wish I could just do something really quick in this 15-minute appointment to make my patient feel better. And the reality is that that's not always possible. But that's honestly where education and social media come in, and trusted guidelines and what we put out that's patient facing, from societies like ISWISH, and then from trusted providers on social media, right? We can really supplement, we can be a resource. So that busy OBGYN that has somebody who comes in that's like, I have low libido, we can say, okay, well, let's set up an appointment to discuss this. In the meantime, here is an account that has trusted information, or here is, information on hypoactive sexual desire disorder that I want you to read about. So when you come back, we can have a more focused discussion. So I think that there are ways that we can move ahead with these conditions.
right. Absolutely. Well, fantastic. Before we go, I'd love to get a couple of pearls or some things that, you'd love to leave the listener with. And then after that, maybe you can tell us how we can get in touch with you.
Yes. So the biggest pearl for patients is that there are causes of chronic vulvar pain. So if you are told that you have vulvodynia, or you do an internet search and it seems that it is vulvodynia, remember that is just telling you that you have pain in the vulvar area. And I really encourage people to push forward to see what the underlying cause is. And something that can be very helpful with that is the book that Dr. Andrew Goldstein, Dr. Irwin Goldstein, and Dr. Caroline Pukal and I wrote. And that's called When Sex Hurts. No, obviously we had to pick a title, and that's what most people think of. But I want to reassure you that if you're somebody that intercourse or sex is not your primary concern, this book is still absolutely essentially helpful. It discusses unprovoked pain. It discusses pain with sitting. It discusses endometriosis. It discusses everything across the board with genitopelvic pain. So do not let the title or the cover deter you. It's really and it's case based, and there's also resources. So if you are a practitioner that feels like you would like to help more of your patients that see that, and you see this, it's really geared towards you as well. And sometimes it helps to see how our counseling translates in layman's terms, because that's what's going to be really helpful in the office. So that's the biggest thing. And then if you're a practitioner, my biggest piece of advice for anybody that evaluates the vulva and vagina is, number one, evaluate the clitoris. And that's a topic for another podcast, but evaluate the clitoris. And then number two, do a pelvic floor muscle examination. And if you just start doing it with your bimanual, so do the top and then go ahead, turn your finger over and do the bottom. And if you're unsure, recruit your friendly physical therapist colleague and have them show you how to do it, and then just start practicing on people, because when you start not practicing but evaluating on people, right? And then when you start feeling, you'll start noticing a difference between a functional pelvic floor and a tight pelvic floor, and then a loose pelvic floor. Both tight and loose are weak. So we really need to, if we could just do that, we would pick up so much of these pain conditions. So those are my two take homes. And then as far as how to find me, you can find me on social media, on Instagram mainly, at Jill Krapf, MD. And then I also have a practice in Tampa, although patients come and see me from far and wide, not only all over the country, but also Canada, South America, Europe, and even Australia. So yes. And so if you would like an appointment, please, you can go to my website, which is www.jillkrafmd.com. We keep it simple. Or you can go through social media and email at appointments@jillkrafmd.com, and you'll speak with my wonderful nurse, Samantha, who will get you set up with either a virtual appointment if you're an international, non-US patient, or an in-person appointment, which is always preferred with these complex pain conditions.
Fantastic. Well, you know what I love about that pearl that you gave is hope. I always love to leave people with hope. I think that sometimes when people have been suffering with chronic pelvic pain or with chronic any type of condition, right, a lot of times they lose hope. So I love to leave people with hope, because then we know that we can hopefully find a solution to their pain and to the problem that they're having. So thank you for doing that. And thank you for all that you do for patients and for practitioners that deal with chronic pelvic pain and with pelvic pain disorders, because I think that that is so, so important and something we don't get enough of. So thank you. And well, I am done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. So if you are having any issues with your vulvar health or having pain, please speak with a practitioner that deals with chronic pelvic pain, or give Dr. Krapf a call, because she is available and an amazing doctor. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.